One of the operations that we commonly perform is called a lumbar fusion. The reason we do a lumbar fusion is if someone has a lot of back pain, and usually there's associated leg pain. And so we're doing a combination of trying to alleviate not just the pinched nerves, but also to alleviate the axial back pain. And that back pain develops as discs wear out. Not infrequently, a disc will collapse completely, and a patient will have essentially a bone-on-bone kind of a phenomenon, and that can be very, very painful. Even sometimes you can get some instability, so even though this model shows that the bones align nicely, sometimes someone will have a bone that slips forward on the bone below or above, and that instability can be the source of a lot of pain. And so we've got to stabilize those bones together by fusing them. And there's several ways to do lumbar fusions. One way is to go through the anterior abdominal approach. In that case, we use a vascular surgeon. We have some very talented colleagues that we work with. They do the anterior lumbar exposure for us. If you're going to have an anterior lumbar fusion, you'll meet those colleagues. I think you'll be very impressed with them. And it does take a little bit of time to schedule that surgery because we have to sync our schedule and their schedule together to find a good day to do your surgery. If you have to undergo an anterior lumbar procedure, just know that when we do that exposure, there's some retraction on the intestines, and frequently that retraction causes the intestines to slow down, meaning when you wake up, you may not be passing gas for a day or two. Unfortunately, we have to keep you in the hospital until your bowels wake up and you begin to pass gas. That usually takes, again, 1 to 2 days. It can take longer. The best thing for that, as is the best thing for most recoveries, is to get up and walk as much as possible after surgery. An example of an anterior lumbar fusion is this. This is a device where we've cleaned out the disc completely and we replace it with a spacer that's packed with bone graft. That allows us to fuse the bones together and have replaced or removed the elements that could be causing some of that pain. Frequently when we do lumbar fusions, we have to put in screws from the back. So another approach to a lumbar fusion is a posterior lumbar fusion. In the posterior approach, we spread the muscles off the roof of the spine. We decompress the nerve roots completely, and that may require taking off all of this bone. And an example such as this, where we've opened up the canal widely and allowed the nerve roots a lot of room. After we do that decompression and we want those bones to be stable together, we'll put screws in the bone. This part of the bone is called the pedicle. These are called pedicle screws, and they're attached to a rod beneath some locking nuts. So a one-level lumbar fusion results in, posterior approach results in 4 screws and 2 rods and 4 locking nuts. When we hear about lumbar fusions and we understand that we're going to have instrumentation, everybody asks, is it going to go off in the airport? It doesn't go off in the airport. It's not steel, it's titanium, and so you don't have to worry about that.